Hello all, so I'm Dominique Tabu, I'm a hepatologist in Paris, France, and it's my pleasure to introduce this very nice session about end-stage liver diseases and transplantation. And I will be sharing this session with my co-chair and friends, Professor Richard Moreau from Paris and Professor Shiv Sarin from New Delhi, that you all know. So for the first talk, it's my great pleasure to introduce Professor Marina Berenguer, who is hepatologist, as you know, in Valencia, devoted to liver transplantation and happened to be the past president of ILTS. And Marina will discuss with us the concept of liver transplantation in ACLF patients. So thank you very much, Marina, and that's your turn.
Hello, I'm Marina Berenguer, hepatologist from Valencia, Spain, and I'll be presenting today on liver transplantation for acute chronic liver failure. These are my disclosures. And as you all know, in the absence of liver transplantation, ACLF3 patients have a very high early mortality. And this is really shown on this table summarizing the short-term mortality rate of ACLF according to stratification. And as you can see, even regardless of the definition used, whether it's the European Association, North American Consortium, the Chinese group, and the Asian Pacific Association, the 28 mortality is very high in patients with ACLF3 or greater, ranging from 64% to 93%. And in fact, if we go to the canonic data, you can see that the prevalence of ACLF3 was only 1.5%, but the mortality at 1 month was up to 77%. These data really contrast with the high short-term survival rates that have been described following liver transplantation in patients transplanted for ACLF3. This is again a table that summarizes several studies, and as you can see, the 1-year survival is close to 80% in most of these series. The studies also highlight that these good outcome survival rates are conditional to a strong selection process. And as you can see in this last study by Arsena in 2020, the 1-year survival ranged between 8.3% and 84%, depending on the TAM score, predictive score that we will talk in the last slide. So overall, liver transplantation is a life-saving option in patients with ACLF3, yet unfortunately, many patients are not receiving liver transplantation. And this was nicely shown in this study, where 351 patients were admitted to the ICU in 20 European transplant centers with ACLF grade 3. 21% of those listed died or removed from waiting list for being too sick. Importantly, there was a very high heterogeneity in terms of transplantability, with only a mean of 8% receiving liver transplantation, ranging from 41% in high listing centers to 3% in low listing centers, with better outcome in the high listing centers. Which was very interesting is to look at the main reasons for not listing patients with ACLF in the ICU. And when they compare the high listing and the low listing centers, you could see that both addiction, comorbidities, and uncontrolled bacterial infection were the main reasons for not listing, similarly in both types of centers. But the difference relied on illness severity. It was the main reason for not listing in about 50% of the low listing centers and only in 1/3 of the high listing centers, really highlighting a great heterogeneity in the management of these patients, particularly in the transplant decision process. Clearly, transplanting patients with ACLF comes at a cost, with a post-transplant healthcare resource utilization, which is substantially greater in ACLF3 patients, which is shown on this slide in strong blue. So the key point in terms of an individual decision on an individual basis is really to decide on transplantability, whether it is futile to transplant the patient that we are seeing, and whether if we decide to transplant, whether we need to prioritize, and whether we should use only optimal organs. And this needs to take into account the equity and efficiency of the transplant process. So in terms of prioritization, there are many studies that have shown that the MEL system is not adequate to stratify the risk of death in patients with ACLF. In fact, in this study from using the UNOS database, the study showed that patients with ACLF 2 and 3, the most severe patients, but with the MEL sodium score less than 25, which is shown in pale blue, had the highest risk of dying or being removed from the waiting list because of being too sick. Again, highlighting that the MEL system underestimates the risk of death in patients with ACLF grade 2 and 3. The second point is that really this is a very dynamic process, and we need to optimally decide on the timing of liver transplantation. This study really shows this data, and you can see that patients that are transplanted with a grade 0-2 at listing and at transplant have the best outcome post-transplantation. But if they downgrade to grade 3 at transplantation, then the post-transplant outcome is significantly worse. And the opposite happens for patients who are listed with a grade 3 at time of listing. If they continue to be grade 3 at time of transplantation, the outcome is the worst. But if they upgrade to grade 0-2, then the outcome is improved, really highlighting that we need to aggressively manage these patients before transplantation. Finally, the topic of futility. There are some risk factors that have been shown to be associated with very high mortality rates after transplantation. These are shown on this slide. I like to highlight age greater than 60 years of age, severe comorbidities, ARDS, the need for high vasopressors, high lactate levels in serum, uncontrolled fungal or multi-drug resistant infection, and transplantation using marginal organs. And in fact, there have been models that have been created to predict outcome without liver transplantation and outcome with liver transplantation. The CLIF ACLF score that predicts outcome without liver transplantation based on the CLIF organ failure score, age, and white blood count cells, that predicts 28 days mortality, and that considers care withdrawal if the score is greater than 64. In term, the TAM model that I mentioned in my first slide that considers age, lactate level, mechanical ventilation, and pre-transplant leukocyte count. And again, that depending on the TAM score, you may have a post-transplant outcome of 84% as opposed to 8% in terms of survival. So these are scores that we need to consider when we are deciding on the outcome of our patients. And finally, what in terms of using marginal organs? This was assessed in this Markov decision process model to determine the optimal timing within 7 days of listing to maximize 1 year post-transplant survival, accounting for organ failure recovery and the use of marginal quality organ. And overall, the results were that in all patient groups, early transplantation yielded the highest survival benefit, even when accounting for donor organ quality. And this was the highest for patients age greater than 60 or with 4 or 6 organ failures due to the high non-transplant mortality. So overall, there's really a high mortality on the waiting list, particularly for ACLF grade 3. And this has been shown in many studies like this very large collaborative study. And in contrast, in selected patients, post-transplant survival is excellent, similar to grade 0 or grade 1 or non-ACLF patients. But in order to achieve good results, we need to understand that this is a dynamic process and we need to optimize preoperatively these patients with a rapid and aggressive management to assure transplantation in a window opportunity, taking into considerations that patients with ACLF with 4 or more than 4 organ failures, with infections with multi-drug resistant organisms, high TAM score, or very high lactate levels, they have the highest risk for post-transplant mortality, and thus we need to decide whether survival benefit must be weighted against the risk of post-transplant adverse outcomes. And we also need to understand that in patients with ACLF3, it may be preferable to accept a marginal organ than to delay liver transplantation, given the decline in clinical outcomes associated with increased wait list time. So I'd like to thank our audience today. And I also like to remind everybody of the global collaborative research effort of 52 centers in 20 countries, the CHANCE studies, supported by ILTS and ELITA, where patients with ACLF2 and 3 are transplanted. Patients with ACLF2 and 3 are not transplanted because there are contraindications. And these patients are compared to patients with very high MEL score, but who have no ACLF. And the preliminary results show confirm the data that I just showed: high mortality for ACLF3 patients not transplanted, low mortality for ACLF2 and 3 patients that are transplanted. Thank you very much for your attention.
Thanks a lot, Marina. This is really amazing, the way that you present things, and this is really a big issue in our patients with end-stage liver disease. And so this communication is open for discussion, and please ask your questions in the chat, and I will have a look and ask them. And maybe I will start right now. We all know, Marina, that there is a window, as you said, where it is complicated. And my question to you is, sometimes you have patients who develop sepsis, and then you increase the vasopressors, the noradrenaline. And so in your opinion, is it correct to say that we cannot go to transplant in patients when you increase noradrenaline or other vasoactive drugs, and you must have a stable process or a decreasing process and a control of septic shock?
I think you need to have a control of the septic shock. This is as an overall kind of response, but I think the decision on an individual basis is always extremely difficult. And the problem is that many of the models that I show and the risk factors and the cutoffs for these different risk factors, they come from retrospective studies where there's always a bias in these studies, because there was always a pre-decision to transplant these patients sometimes in these studies. So the patients were most of the time in these retrospective studies were pre-selected, and we don't really understand what the selection process took place. So overall, I consider that we need at least to have a 24-hour control of the septic infection, but finally, the decision needs to be individualized and should be based on many, many other factors.
And thank you, Marina. I completely agree with you. This is always a case-by-case discussion, and also including the way the patient is living and maybe the etiology of cirrhosis. And so we have one question about the etiology of cirrhosis. So do you see any differences in ACLF in the regarding the etiology of cirrhosis? Are there some etiologies that are at better prognosis than others? This is a question in the chat.
So I don't think, I mean, that I've seen a different outcome in the patients, but most of the patients that I see, I have to see particularly are alcoholic patients that are decompensated, and mostly they are alcoholic patients. And I'm not really sure the reason behind, maybe because it's of the immune system. But I don't think it's really the etiology. I do think it's more other factors. We never take into account, for instance, their fragility, their status in terms of fragility. The age, I think, is super important, and also comorbidities. In fact, there are some aspects that are very related to the severity from a point of view respiratory and cardiovascular, but then there are other risk factors that are more general in terms of the general condition of the patient, which I think are extremely important.
Well, thank you very much for this very clear answer. Maybe Shiv or Richard, you have one question to ask Marina?
Yes, Marina, may I ask you a question very quickly? Do we have results about living donors in this context?
We do have results with living donors, and in fact we have data from India, some studies from India, and I think they show that this is feasible. I mean, and the results can be good, but I think also the main problem that we don't have a lot of information, because also the definitions of ACLF are different in different regions of the world, so it's a bit difficult to compare sometimes the studies, but there are studies and they show good results. Not a lot of data.
And of course, the new ARC system to assess the severity of patient finally is very, very close to our system, and because they assess the several organs function, and therefore I think we should reconcile the two worlds.
I think they're very close, but they have also different. I mean, the problems we need, as you know, a prospective study, because the problem is, as I mentioned before, it's the only way to determine contraindications to liver transplantation in ACLF3 and more than 3 without selection bias. I think that this is a huge problem. For instance, with the UNOS database studies, I think there's a bias because all these patients have been pre-selected.
Yeah, I completely agree with this, and thanks for reminding us the large collaborative study, and this will be very important, all of us, all the liver transplant centers, to include patients and to have definite answers at the end. Maybe a last question, maybe Shiv, if you have a question for Marina?
No question. I think it's a very nice presentation. I think for futility, it is clear a recent consensus in our place was also held on futility, where we have 90% as living donor with reasonably good results. Most of them are alcohol-related liver disease. The question remains that a patient who is septic, especially had an SPP or has been on dialysis, whether he should take it, because in living donor, there is no question of choosing the organ, but it is choosing the donor. And therefore, it's a bigger burden for us not to deny a donor is a bigger issue, because the donor wants to donate due to emotional reasons. And that is every day we feel, the wife or the brother or the mother. But to say no, criteria are limited, but few things are clear, that the patient has an active uncontrolled infection or fungal infection or is on dialysis recently. Those patients we generally would not take, they are futile. We use an ARC score, APSL ACLF Research Consortium, which is very simple. And if ARC is above 11 or above on day 1, the patient is prognosticated and transplant workup is done. So in living donor, we can get an organ in 3 days' time. That's the advantage. The disadvantage is that you have to say no to 8 out of 10 patients donors.
Yeah, I think we need to. I think the prognosis factors will be probably some of them are going to be different when we assess the living donor. So we will need to have recommendations from the living donor arena and from the deceased donor, and then we have now the machine perfusion that will probably have also an impact, because I think for these patients, you can use suboptimal organs, it's better to use the great organs that function much better initially.
Okay, this is a fascinating discussion, and we will have to move on, but we can flow it later on. And so now, Richard, I leave you introduce our second speaker.
Yes, thank you. It is my great pleasure to introduce Professor Didier Samuel, Professor of Medicine in Paris, but now is CEO of the INSERM, the French NIH, since January 23, and it's a huge mission for him. And I would like to invite him to discuss COVID-19 and end-stage liver disease.
Thanks to Patrick Marcelin for this kind invitation, and I will discuss COVID-19 and end-stage liver disease. There are some potential mechanisms of liver injury in patients with COVID-19, endotheliopathy with coagulopathy and inflammatory reaction, immune dysregulation, and also hypoxic ischemic injury, and maybe in some cases drug-induced hepatotoxicity. So liver can be affected by immune dysregulation, cytokine storm, endotheliopathy, and drug-induced liver injury. So we think that in the liver there are some liver sinusoidal endotheliopathy with liver injury in COVID-19, as shown on this slide, which may cause since SARS-CoV-2 has a tropism for cell-expressing angiotensin-converting enzyme 2 receptor, and also ACE receptor are expressed in cholangiocyte and hepatocyte. Finally, many studies have shown the impact of COVID-19 in patients with advanced liver disease. You can see on this slide that patient with either chronic liver disease on cirrhosis CHI-PUG A to C. You can see that this is the representation of patient hospitalized, patient in ICU, ICU admission, renal requirement therapy, invasive ventilation, and death. And you can see that there is an impact on death and ICU admission of COVID-19 in patients with severe CHI-PUG C chronic liver disease. You can see also that the increase of acute decomposition and fatality rates according to CHI-PUG and CLIF C organ failure score in case of COVID-19 infection is shown also here, with a proportion of patients with decomposition extremely high in patients with CHI-PUG C, and also in patients with an increase in organ failure score, and so a risk of death extremely high in patients with COVID-19 and severe chronic liver disease. The incidence of severe COVID and acute liver injury seems clearly to increase with cirrhosis stage, as shown here. This is the incidence of severe COVID-19, and you can see that it is high in decompensated cirrhosis. You can see also the mortality, and you can see the link and the relationship with the CHI-PUG score. Clearly, there is a high mortality rates in this study with in patients with pre-existing cirrhosis. This is 125 patients with chronic liver disease, and you can see that there is a relationship between those with CHI-PUG C and risk of death, in contrast to those with CHI-PUG A, which is not so benign as you can see here, but there is a relationship between severity of cirrhosis and risk of death, as shown here. There is also a higher mortality in patients with cirrhosis and COVID-19, but in this study, similar mortality with patients with cirrhosis without COVID, as shown here. And in this study from India, acute chronic liver failure is the main driver of mortality in patients with COVID-19 and cirrhosis. In 192 patients with chronic liver disease, you can see that 32 here develop a CLF, and in these patients there was a respiratory failure and renal failure. ACLF is in this study the main driver of mortality in patients with COVID-19 and cirrhosis. In this multivariate analysis, you can see that the presence of ACLF grade 3, the OR is 18. In this study from US, there was a relationship between the development of cholestasis, secondary sclerosing cholangitis after COVID infection in almost 500 patients. And you can see the value here of alkaline phosphatase is increased, as you can see. And 23% of patients with chronic liver disease develop cholestatic liver failure here, with a cholestasis plus bilirubin elevated. And 50% in this study develop secondary sclerosing cholangitis. What was the impact of COVID-19 on the transplant activity in the US and in France? You can see on this slide that the number of transplantation per day in kidney transplantation decreased sharply in the US. There was also a decline, but less important, in liver transplantation in the US. In France, kidney transplantation was completely stopped, as you can see here, but liver transplantation declined sharply, but was not completely stopped, and some centers continue to perform liver transplantation, but there was a decline during the period of COVID in 2020. Also, what was the impact of COVID-19 in patients on waiting list for transplantation? In this study from Europe, you can see here the survival probability of patients with liver cancer and child A cirrhosis, patient here with decompensated cirrhosis. According to the MELD, patient with MELD below 15, there was a minimal impact on survival, while COVID-19 has a strong impact on survival in patients with MELD over 15. Patients who develop dyspnea on the waiting list have a poor survival in comparison with patients without dyspnea, as well as patients who develop kidney failure in comparison to patients without kidney failure. We have a better result in our own waiting list. 91 patients were included on this waiting list, and you can see that 16% were developed COVID-19. You can see that only 3 of these 15 patients were admitted in the hospital, 2 in the ICU, 2 required liver transplantation, and 1 patient died from PRES syndrome. So the global overall, in our experience, the impact on the waiting list was quite minimal. Finally, what is the position regarding vaccination and treatment? In this guideline paper from EASL, vaccination was recommended in patients with cirrhosis and liver decompensation and in patients with HCC. Again, the impact of vaccination in this paper in patients with chronic liver disease shows that the COVID-19 incidence was reduced after 1 dose at minimal of mRNA vaccine in patients with chronic liver disease, but there was no difference in incidence of hospitalization and COVID-related deaths in this series. But it has been shown also that the rate of seroconversion in cirrhotic patients after a second vaccination was quite high in this series, and so the recommendation to vaccinate patients is really very high. There are some cases of autoimmune or autoimmune-like hepatitis in patients with after vaccination, as shown in this paper, which shows that at a median of 15 days after vaccination, some patients develop immune-mediated hepatitis, which resolve mostly after steroid treatment. So at the end, it is possible to treat a patient with nirmatrelvir plus ritonavir Paxlovid. This is possible in patients with cirrhosis, but difficult to use in patients with decompensated cirrhosis, and almost impossible in patients with liver transplantation due to the presence of ritonavir. And the monoclonal antibody Evusheld has shown efficacy for the prevention of COVID-19, as shown in this series. So in conclusion, COVID-19 is related to an increased mortality and morbidity in patients with end-stage liver disease. SELF is the main driver of mortality in cirrhotic patients infected by SARS-CoV-2. Vaccination in end-stage cirrhosis is recommended to prevent severe forms. Clinical trials should be performed to test the efficacy and the tolerance of COVID treatment for patients with advanced liver disease. And this is the team at Paul Brousse Hospital, and I thank you very much for your this invitation and also for your attention. And I thank also Dr. Ilias Kounis for his help to build this presentation. Thank you.
Thank you. Thank you, Didier, for this nice overview of COVID-19. Maybe Dominique or she would like to ask some question. In the meantime, yes, Shiv, what dose of steroids? Yes, please, Shiv. Yes.
Yes, we see these patients and they were being referred all across India to us post-transplant or waiting for transplant. The question we faced, and we need your guidance, is what dose of steroids in a COVID lung and a patient who has got decompensated cirrhosis with sepsis and maybe septic shock. Which steroid and how much dose, how long?
I think we have no data in cirrhotic patients regarding the exact dose of steroid should be used in patients with cirrhosis who develop COVID-19. And I think you should adapt to the classical criteria in patients with COVID-19 and severe lung disease. I think steroids in patients with decompensated liver disease and COVID-19, steroids should be used only in case of severe pulmonary infection. and not in other cases.
The role of plasma exchange or IVIG if you don't give steroids.
I have no answer regarding this. I have no experience regarding plasma exchange in this situation, and I am not sure there are some data and some regarding this. I don't know if you have this experience, but I have not this experience.
So when the patients would come and they were sick and we know he's septic and we cannot use the steroids and the bilirubin levels were high, we used to do a low volume or normal volume plasma exchange for 1 or 2 days because the ferritin would be 5,000 or 10,000 and patient would have something like an HLH. We rarely used IVIG and we had at least 2 plasma exchanges were able to help many of our patients. But these were all, patients who were soon after transplant within, let's say, 30 days to 60 days, or were, salvageable. They had, otherwise we would not use plasma exchange. One brief question is, have you used remdesivir in high CT value of a patient? CT value is 16, 18, and what would you do? Antiviral.
Antiviral therapy, we have not used pavloxide in this patient and not in the transplant patient because it was there is some ritonavir in the treatment and it was difficult to use. We have mostly used the monoclonal antibody rather than the antiviral treatment in this patient.
Okay, thank you.
Have a question from Marina. Would you use donor with positive for SARS-CoV-2?
Now, yes, we have recently used we have performed recently 2 transplantation with donors who were COVID SARS-2 positive without severe symptoms of COVID infection. So they were found positive at a routine test, but there was no symptoms of COVID, and we have used these 2 donors without any specific issue. I shall say that most of the data I presented are based on the COVID experience in 2020. I think we have still not too much data regarding the Omicron variant, which look at less severe as the first COVID infection in 2020.
I'm sorry, we have to move to the next talk. Didier, thank you again.
Thank you.
See you soon.
Thank you. I would like to take the pleasure of introducing Christophe Moreno, a very renowned hepatologist, director of gastroenterology and hepatology at the Free University of Brussels, and also currently the president of the Belgian Liver Society. And he would discuss a very important topic close to many of us, is the role of TIPS in decompensated cirrhosis of the liver. Is it going to change? Is it a game changer? Should we do it early enough? And whether the patients can actually be taken off transplant? Many of these issues, and I invite Christophe for this very important talk. And I want to thank Patrick Marceline for inviting me. Christophe, please.
So good afternoon. First of all, I would like to really thank the organizers and particularly Professor Patrick Marcelin for the kind invitation. And it's my great pleasure to give this talk on TIPS in decompensated cirrhosis. So as you know, TIPS has 2 main indications in cirrhosis, varicose bleeding and ascites. And I will focus my talk on ascites. So ascites is the most common cause of decompensation in a patient with cirrhosis, with an annual incidence of approximately 5 to 10% of the patients. Moreover, the occurrence of ascites significantly impairs the prognosis of the patient with a 1-year survival of around 30%. Median survival is reduced to 6 months when ascites becomes refractory. So a pathophysiology of ascites in cirrhosis is complex. The starting point is the development of portal hypertension due to increased resistance to portal outflow. This increased intrahepatic resistance are due to architectural changes, but also to functional changes and systemic inflammation. The increase in portal pressure will promote by different mechanisms splanchnic vascular dilation and formation of portosystemic shunts. And together, this mechanism will induce a gradual reduction of the effective arterial blood flow, which in turn will activate different compensatory mechanisms to expand the total blood flow, to increase the cardiac output, but also to lead to sodium and water retention, which will ultimately lead to ascites formation and hyponatremia. So TIPS for transjugular intrahepatic portosystemic shunts acts as a low resistance conduit that reduces the blood flow that redirects the blood flow from portosystemic collaterals towards the portal vein. By directly connecting the portal vein to the inferior vena cava, TIPS is very effective for reducing the portocava pressure gradient, a reduction estimated to minus 60% in previous studies. After a highly variable time from days to weeks, the cardiocirculatory, neurohormonal, and renal response to TIPS insertion will improve the control of ascites and may improve survival in selected patients. Indeed, TIPS has been proposed in selected patients with cirrhosis and ascites with refractoriness to medical therapy and may increase transplant-free survival. However, the efficacy, meaning control of ascites, improved quality of life, and improved survival, and the risk of side effects of TIPS, like hepatic encephalopathy, may also liver failure or cardiac decompensation, depends on the interplay among multiple patient characteristics, like the degree of liver dysfunction, the type of ascites, so recurrent versus refractory, cardiac function, and renal function being probably the most important characteristic, and I will discuss those different points. So, as you know, hepatic encephalopathy is the main complication of TIPS and is associated with a reduced quality of life and an increased mortality. The main risk factors for the development of post-TIPS over hepatic encephalopathy include prior episodes of hepatic encephalopathy, advanced liver dysfunction defined by a child PHC or a melt above 18, an older age, an increased creatinine level, hyponatremia, and also sarcopenia. So different prognostic models that I will not develop today have been proposed in order to improve the selection of patients and minimizing the risk of side effects and the risk of mortality. The FIP score from the Freiburg team is one example, allowing to identify high-risk patients with a poor prognosis. And although helpful, all these studies and all these prognostic models have some bias, such as the retrospective nature, inclusion of an heterogeneous population of patients, and lack of strong validation that limit their use in clinical practice and at the individual patient level. So another point concerns the importance of ascites definition on the outcome. Refractory ascites refers to ascites that cannot be resolved or that recurs very early after large volume paracentesis and cannot be prevented by medication. According to the original criteria of the International Ascites Club, recurrent or recidivant ascites is defined as ascites requiring more than 3 large volume paracenteses within one year despite sodium restriction and an adequate diuretic therapy. And recently, in a randomized controlled trial assessing the impact of TIPS on survival, recurrent ascites was defined by the team of Christophe Bureau as ascites requiring at least 2 large volume paracenteses within a period of at least 3 weeks. So most available data on the usefulness of TIPS in ascites concern patients with refractory ascites and not recurrent, who receive bar stents. So the old stents that we don't use today anymore. So different meta-analyses evaluating the usefulness of TIPS in refractory ascites came to the conclusion that TIPS was effective in preventing ascites recurrence in almost half of the patient without worsening the risk of hepatic encephalopathy. The individual patient meta-analysis published by Salerno et al., which include data from 4 of the 5 randomized controlled trials available at that time, identified a transplant-free survival benefit in the TIPS group. However, we are now in the era of the cover stents with less TIPS dysfunction, and only one randomized controlled trial assessing the usefulness of TIPS in patients with recurrent ascites was published. So in this study published by the group of Christophe Bureau, the 1-year survival rate of patients in the TIPS group was significantly higher than that of control patients treated with standard of care and, of course, large volume parasites. And in addition to these benefits in survival, hepatic encephalopathy did not occur more frequently in the TIPS group. And of course, the number of parasitosis was drastically reduced in the TIPS group. So although the current guidelines allow the use of TIPS both in patients with recurrent and in refractory ascites, the robustness of the definition proposed by Christophe Bureau and colleagues for the identification of patients who would benefit from TIPS insertion needs confirmation in further independent studies. Furthermore, it is still unsettled whether an earlier placement of TIPS may influence the long-term outcome of patients with cirrhosis and ascites. It is also of major importance to remember that several non-hepatic factors may affect outcomes after TIPS insertion for ascites. Recent data suggest that cardiac decompensation occurs in 10 to 20% of the patients after TIPS placement. And as you know, TIPS cause a sudden increase in cardiac preload, and therefore in patients with pre-existing alteration of the cardiac reserve, this cardiac hemodynamic stress may result in cardiac failure. So, although the recent guidelines recommend a detailed assessment of the cardiac function in TIPS candidates, those guidelines also acknowledge that accurate markers of cardiac dysfunction are currently lacking. In a recent prospective study assessing the risk of heart failure after TIPS insertion, several cardiac echocardiographic parameters reflecting diastolic dysfunction, like the E/A ratio, the presence of an aortic stenosis, a pre-TIPS elevated brain natriuretic peptide, and an N-terminal pro-BNP were associated with the risk of post-TIPS cardiac decompensation. Interestingly, a pre-TIPS level of BNP below 40 picogram per ml and an anti-pro-BNP below 125 picogram per ml allow to identify patients with a negligible risk of cardiac decompensation after TIPS insertion. So the ideal candidate for TIPS in the setting of cirrhosis and ascites is a relatively young patient with no history or no overt hepatic encephalopathy, a total bilirubin level below 3, platelet count above 75, a child pulse score below 13, a MEL score below 19, a normal value of BNP and T-proBNP, no aortic stenosis, and no diastolic dysfunction, and at the cardiac echocardiographic evaluation. Of course, we don't see this patient very frequently in clinical practice, and the decision to place a TIPS is on a case-by-case decision. So there are, of course, several unsettled issues. First, the optimal post-TIPS Porto-Cava pressure gradient needed to control ascites remain controversial, and most of the studies are relatively old and include patients with bar stents. Stent diameters may also influence the efficacy, but also the risk of side effects. Old series suggest that larger cover tips, so 10 millimeters, were superior to smaller stents, like 8 millimeters, in the control of refractory ascites. However, recent studies suggest that the probability of post-TIPS hepatic encephalopathy increase with the diameter of the shunt, and therefore that probably 8 millimeters is safer than a 10 millimeters TIPS. So according to the international guidelines, a small TIPS is currently recommended for the treatment of ascites in cirrhosis. However, the definition of small TIPS remains unclear, but everyone agrees that the TIPS have to be smaller than 10 millimeters. So a stepwise approach that does not target a given reduction in portocava pressure gradient may be a good pragmatic approach to TIPS placement for ascites. So using this approach, one could start with a small TIPS, for instance, an underdilated 6 millimeter diameters, and progressively dilate the stent graft based, of course, on the clinical response, the cardiac tolerance, and the development or not of side effects like hepatic encephalopathy. Of course, this kind of approach has to be tested in randomized controlled trial. So, dear colleagues, in conclusion, in selected patients with recurrent or refractory ascites, TIPS using cover stent graft improve control of ascites and survival. Identification of the appropriate timing for TIPS placement is essential to prevent further decompensation and improve survival. The optimal portocava pressure gradient decrease after TIPS to control refractory ascites remains unclear. A one-size-fits-all strategy clearly seems unrealistic, and a stepwise approach of progressive stent dilation seems more appropriate to optimize control of ascites and to minimize adverse effects. I thank you for attention.
Thank you, Christophe. That was a very comprehensive and updated view of TIPS in decompensated cirrhosis. Two of our colleagues would like to ask questions. Dominique Thabut may first ask a question, please.
Yeah, thank you very much, Shiv, and thank you very much, Adrian. Christophe, sorry, this was a very nice talk. My question is, in the setting of refractory or recurrent ascites, and we can discuss the difference between the two settings, when do we have to discuss also liver transplantation? What I mean is, what we do in our unit, and I don't know if many people do that, but that's how we feel we have to do, is we discuss always TIPS and transplant together. Not to say if it doesn't work, we will transplant the patient, but to discuss before in order to know if there is a complication of TIPS, should we go or not for transplant, and we decided before. So even if the TIPS is a little, well, we have side effects of the TIPS and the liver decompensation, for example, or encephalopathy, we don't feel that we have to transplant patients when we decided before we should not, or we decide, okay, we go for a workup pre-transplant because this TIPS is at risk. And then if there is an issue, we go for transplant. So, and for some patients, of course, we say, okay, TIPS is not a good option and the guy is good for liver transplant, and we go right now for liver transplant. So what is your experience in discussing the two together?
Thanks, Shiv. Thanks, Dominique, for this excellent question. So I agree with you. When we have patients who are at risk of complication after TIPS, clearly we perform a pre-transplant workup, and it's clear that it's better if those patients make a complication around encephalopathy, for example, are candidate to transplantation. Of course, some patients are contraindicated for transplantation for many reasons. For example, alcohol addiction still in place. So in this case, we try to take less risk, and clearly if patient has a previous episode of hepatic encephalopathy, renal function, etc., we are more prone to exclude those patients for a TIPS. But I think it's always a difficult decision, because for those patients excluded for transplantation, of course, in refractory ascites, we don't have other option.
Yes, thank you. I have limited time, and I just would ask one question. Maybe some experience that we tried using 6 millimeter and 8 millimeter stents. The ascites doesn't get decompressed, number one, and the patients continue to need albumin and continue to have LVP done. So my question simply to you is, in your experience, what percentage of patients would require a repeat albumin and paracentesis maybe for a year?
Okay, if we put tips at 6 millimeters, that's the question, or in general?
No, in general, 6 and 8 don't work very well.
I would say that approximately 40 to 50, a little bit 50% of the patient do not need a large paracentesis after that. In additional 20 to 25 patients, we need paracentesis with a decreased frequency. And yes, in 20% of the patient, we don't have good results.
Okay. This is very good. And I also just one quick comment is that we rarely get people with proBNP of less than 125. It's a dream, but most people have 400, 800. With that, thank you, Christo. We don't have more time, and a big round of applause for you.
Thank you.
And allow me to just introduce a dear friend of mine and a very renowned hepatologist, Adrian Guerrero, who is from Argentina, Buenos Aires. He's a professor of gastroenterology and hepatology and an excellent portal hypertension man, and now also an acute and chronic liver failure expert. He also is a member of the Ascites Club. With that, and he has a difficult case, so please pay attention if you have to ask questions and to learn. Adrian, the floor is yours.
Thank you, Shiv. Good afternoon to everybody. I'm going to present a case, but first of all, I want to thank Patrick Marcelin and Marc Boulier and the organizers for inviting me to this outstanding meeting. I'm going to present a clinical case on acutely decompensated cirrhosis, trying to summarize the main aspects of this complication. I have no conflicts of interest concerning this presentation. And the case is a young man of 45 years with a history of alcohol heavy drinking, 2 liters of wine for at least 15 years, that he had increased during the last 10 days. He arrives to ER with abdominal distension, jaundice, and bradypsychia as an expression of hepatic encephalopathy. He shows increased bilirubin to 5.2, a moderate increase in AST and ALT, prothrombin time of 42%, and a normal creatinine at that time. Abdominal ultrasound shows signs of cirrhosis and moderate ascites without evidence of SVP. It is therefore quite clear that this patient has an acutely decompensated cirrhosis, or ADC, since he developed at least 2 events, ascites and encephalopathy. We could discuss later if jaundice is an additional event defining acute decompensation. But now, an important question here is if the patient has, in addition, ACLF, acute and chronic liver failure. So here we are going to vote. We have 4 options as answers to this question. The first one is no, because acutely decompensated cirrhosis and ACLF exclude each other. Second is no, because criteria for ACLF are not accomplished. Third, yes, the patient has both acutely decompensated cirrhosis and ACLF. And 4, yes, the patient has ACLF because he has a short in-hospital survival rate.
People have to vote, or if they are, is there a mechanism by which you would like to raise hands and comment? In my opinion, just to kick the ball, I think it may be the patient has probably acute decompensation and ACLF put together. We don't have to have, at least in our setup, an organ failure. The patient has ascites, encephalopathy, and jaundice, which Bavino says is not a part of the is not necessarily a part of decompensation, but this patient is there. He's been drinking alcohol. So I think it is acute decompensation and presenting as a CLF. So probably 3 is correct. Adrian, you can give your
Okay.
comment.
Sorry, Chief, but there is a vote and the majority said no.
Okay.
Because criteria for ACLF are not accomplished. In 67% of people voting.
So
Okay.
2/3 said no, which number 2, which was the correct answer, because criteria for ACLF were not accomplished, and I'm going to show that in the next slides. So, what is ACLF? It's an episode defined as an episode of acutely decompensated cirrhosis associated with single or multiple organ failure, characterized by the presence of an intense inflammatory systemic response and a high risk of short-term patient mortality. That is to say, more than 15% mortality in the 28 days after admission. And this is a very dynamic complication. So the patient can move from decompensated cirrhosis to ACLF and inversely. And we have to take into account that when we establish the diagnosis of ACLF, this is a very relevant definition, because it is clear that in a patient with ACLF, the prognosis is much lower, as was shown by Charles Moreau in this years ago in this figure. So how we define ACLF in a patient with decompensated cirrhosis? Of these 6 parameters that you see here, respiratory, coagulation, liver, cardiovascular, neurological, and kidney, there may be dysfunctions and failures, and diagnosis and grading are quite easy to establish according to the number and severity of the compromised organs. So we have ACLF grade 1 if the patient has 1 organ failure and that failure is renal, or if he has 1 non-renal failure plus renal or neurological dysfunction, or grade 2 if he has 2 failures, or grade 3 if he has 3 or more failures of these 6 organs. If these are not accomplished, we can talk all about acute decompensation without ACLF. Since our patient only had grade 1 encephalopathy, he did not qualify for the definition of ACLF. So your answers were correct. And therefore, we can only say he had acutely decompensated cirrhosis. Taking all together, patients with this complication have a 90 days mortality of 24%, as you can see here. But at day 3, the patient got worse. Bilirubin raised to 10, proton pantalla decreased to 38, with a diagnosis of acute alcoholic hepatitis and a moderate score of 38, he was put on steroids. The Lille score calculated at day 7 after steroids was 0.6. So prednisolone was discontinued. Liver transplant evaluation or workshop was performed by a multidisciplinary team, and the patient was listed for liver transplantation. And this patient, we can see he had a bad outcome. So the question we may ask ourselves here is if all decompensated cirrhosis mean the same? And the answer is no. Decompensated cirrhosis covers a very heterogeneous universe of patients. And this was very nicely shown in the PREDICT study that could identify 3 different clinical courses of acutely decompensated cirrhosis with different prognosis and pathophysiology. And as you can see here, the author classified decompensated cirrhosis in stable decompensated cirrhosis that included patients who are neither readmitted nor developed ACLF and showed a 1-year mortality of only 9.5%. The second group was unstable decompensated cirrhosis, including patients who required 1 or more readmissions, but not developing ACLF. And these patients had 3-month and 1-year mortality rates of 21 and 35%. And the more severe group was the pre-ACLF group, that were the patients developing ACLF within 3 months after admission. And they had 3 months and 1-year mortality very high, 54% and 67% respectively. So what happened with our patient? At day 7, total bilirubin was 17, prothrombin time fall to 25%, and encephalopathy progressed to grade 2. And therefore, at this time, this patient with 2 organ failures and 1 organ dysfunction had now ACLF grade 2. And this is obviously associated, with worse prognosis, since the prognosis here was almost 60% of mortality at 28 days. Systemic inflammation is a key driver of ACLF, and after acute liver injury, as it was in this case acute alcoholic hepatitis, inflammatory inducers are liberating, determining systemic inflammation, decreased energy, immune-mediated tissue organ damage, and organ failures. And this is exactly what happened in our patient, who finally developed ACLF grade 3 at day 10. He had a severe liver failure, but in addition, he added other organ failures as kidneys, circulation, lungs, coagulation, and brain, requiring mechanical ventilation and vasopressive drugs. So ACLF grade 3 and a PHC ACLF score of 69. So here is the second question. Now, in this patient, at this stage, there's a call offering an organ to this patient. And the question is, would you accept it and proceed with the transplant? And the options are absolutely yes, absolutely no. I would decide according to PHC ACLF score, or I would decide according to other scores, like, for instance, the TAM mode. You have some second time to vote.
So, okay, please vote.
We have a divided house.
Yes. Yeah.
Of course, your question is so good, and it needs more explanations from you. Maybe I will comment at the end, but here you have 1, 3, and 4. What would you do?
Well, the question is very difficult, and it's the question, this was a real case, and it's a question we ask ourselves. Yes. As you know, I have no answer for this. There's no correct answer, because he was very young, but at the same time, there was multi-organ failure. And as Marina said at the beginning, this is, and Dominique also, this is a case in which we have to take the decision on the very individual basis. On one side is young, on the other side is very sick patient. We can consider futility with liver transplantation. So I think we still don't have the excellent tools to define this or to answer to this question right now. We will have the CHANCE study, we have other studies on ACLF and transplantation, and I think that we need more information, and we cannot rely on just 1 score or 2 scores or numbers we have now.
Again, I'll just give you a very brief comment. This case is so educative. I compliment you. If we were seeing this patient in Asia, we would have diagnosed in the very beginning that this is ACLF. We would not have waited, and we would have worked, because the patient had jaundice, ascites, encephalopathy, and his ARC score would be above 10. Now, by waiting for 5 or 7 days, of course, we would have made him better by ICU admission and treatment. So I would have probably thought, rather than steroids, it's not this case, we would have probably planned a transplant much earlier than going into the ventilator or going into organ failure. So maybe we could have offered him, when he was ACLF2, according to you, a liver transplant early enough. So my feeling is we should have maybe acted a bit earlier, but right now it may be a bit late. But I'll ask Dominique and Marino and others whether, I would say now it is a bit futile.
Dominique?
Well, I think I would have tried to go for it, but it depends also on the patients, the family, etc. And that's from my side. I think we have also other questions from the chat. So let me just restart the chat. Is somebody seeing the chat? No. Okay.
There are comments by Marina. You need to include the psychiatrist evaluation here. I fully agree with her. And also she said depends on donor rate and waiting list. First episode. It is the first episode for this patient. And I think that the criteria established by Philippe Mathurin, for example, could be useful in this patient.
Okay.
Yes, I totally agree. We decided this, it's on a multidisciplinary team, as it was stated just by Philippe Mathurin, and where there are also, residents which belong to the unit, external actors. And concerning what you say, Chief, yes, of course, we would have loved to transplant this patient when he was ACLF2, but we did not have an organ at that time. And this last decision was not to proceed with transplantation. The patient was too sick, vasopressors doses were rising, so we did not, and the patient died 2 days after. So we took another patient to the transplant.
Yeah, just has a question who's probably says that isn't it more difficult in living donors as done in Asia? So just Bajaj has asked you, Adrian, this question. Suppose you have a living donor and suppose the donor is available and the patient was drinking till 10 days ago, what would you do? There is a donor available. What would you do?
I would not be very enthusiastic since we don't have data, as Marina said at the beginning, but in this patient, first, living donors did well in fulminant hepatic failure, even in, not very severe. And this patient, in fact, is completely different, but it's an inflamed patient that I think he needs a full organ and a good organ. Even in cadaveric, I would not take a bad organ or marginal organ for these patients.
I will give you what we do for a living donor. If this patient would have come and there was a donor, and we know that this patient would otherwise die in a week or two, if he had not gone on a ventilator, maybe we would have worked up a few days earlier. And if the psychiatrist would have cleared, maybe we would have, and most centers in the country would have taken him for a transplant, knowing otherwise he would die. So when he has a bilirubin of 17 or 25, I think without a ventilator, we could have considered, but it's a case-to-case basis.
Okay. Well, just like my take-home messages, that is what we said at the end. So I want to thank you and thank you very much to all the audience. Thank you.
Thanks a lot.
Thank you. Thank you, everybody.
It was a pleasure. Thanks, Patrick, for inviting us.
Yeah.
Thank you.
Thank you, Patrick, again. Thank you.
Patrick, and thank you, Ben, and everyone.
See you soon, everybody. See you
Bye-bye.
soon. Bye-bye.